start. Good morning, everybody. We're waiting to hear where our other guest is. I'm sure John's in transit. So again, welcome members, guests and members of public and those watching from elsewhere to this morning's Police and Crime Committee meeting. Our main item today with invited guests is healthcare in custody in London. Members of public may as ever wish to follow us on Twitter, London Assembly, and or take part in the meeting discussion, hashtag healthcare in custody. As ever, kindly turn phones to silent. Initially, apologies for absence, please.
Thank you, Chairman. Apologies have been received from Assembly members Arbour, Duval, Eshalomi and Whittle.
Okay, thank you very much for that. Declaration of interest. Can I ask the committee to note the recommendations set out at item 2 and, as usual, ask members to declare any other disclosable interests that they may have but are not therein contained. Thank you. Item 3, minutes. Can I ask the committee to confirm the minutes of the meeting of the committee held on the 7th of February to be signed by me as a correct record? Thank you. Item 4, summary list of actions. Can I ask the committee to note the completed and ongoing actions arising from previous meetings as listed in the report? Okay, thank you very much. Right, this is good. So we now go to the main item of business. Welcome all of you. I think some of you, many of you have been here before when we had the round table meeting, and I thank you very much for that. If I look at you in a rather odd manner, yesterday I picked up my first pair of varifocals. Ooh, so don't take it wrongly if I start looking all over the shop. I'm doing my best, so you're guinea pigs this morning, so bear with me. So we're going to move into the main set of questions. As I say, we're missing John, and I'm sure he's on his way, but I'll pick up with the first question. Now, this is obviously a subject this committee has covered in the past, an early report, and that we feel very passionate about. We have had visits to custody centres in Lambeth, and as I said earlier, we had really useful roundtable discussion. We're going to take this morning's work, and then we're probably going to work towards potentially an outcome report that we will share and ask for opinions around that. But I'll ask the first question, which is really talking about the Met's existing model for healthcare and custody, which I know is under review, which I'm sure we will hear about. So specifically, I think to the two doctors initially, if I may direct this, what changes, if any, have you noticed in the healthcare needs of detainees coming into custody in the last few years? Gentlemen.
Yes. So over 20 years of assisting with providing medical services to the Metropolitan Police, there has been a considerable change in the complexity of problems that we encounter with our average detainee. We are seeing a lot more complex mental health problems that overlap with drug and alcohol dependencies. That makes the medical management of these individuals particularly difficult. Obviously, there's the physical vulnerabilities that involve individuals needing regular reviews and medication, in addition to psychological vulnerabilities where individuals may need assistance with appropriate adults. The difficulty that we've had on top of that is we've ended up with obviously a shift in provision of healthcare from an entirely doctor-led service to a mix of nurses who are primarily housed in large custody suites where there may be 30 or 40 cells. The issue there is twofold. We find that there is a variable quality of expertise in the range of qualifications perhaps that the nurses have. So depending on the actual individuals that we help to assist, they may need more or less supervision and advice.
This has been increasingly so over that period of years that you've talked about.
That's right. So the present system is that there, I believe there are about 8 or 9 custody suites that are supposedly 24/7 nurse cover. The primary difficulty and anxiety for the medical team, for the doctors, is that although we had been guaranteed a very resilient service where we wouldn't be left without nurse cover, we're now progressively stretched when there's an absence of a nurse to cover not only the custody suites that we were originally planned to look after, but in addition to that, we are stretched to look after a large custody suite that really needs a constant medical attendance.
Yeah, and I'd echo what Aman says. I think part of my areas of research are the needs of patients in custody. And one of the aspects of the complexity relates to the fact that many of our patients are older with more complex medical conditions. Added to that is that the ability to, for example, refer to the emergency departments or to use the ambulance services, which themselves are hugely stressed, means that sometimes, and it applies to nurse colleagues as well, is the availability of the referral that we need is not there. But overall, the nature of detainees, of patients that we're seeing through custody has substantially changed. We're seeing much less drug and alcohol, well, certainly drug problems, but the physical needs are often the ones that are frequently neglected because it's difficult to identify where to refer people on. Frequently people don't have contact with primary care physicians or general practitioners. So that is an issue. Colleagues, as John will no doubt say, there is a range of skills of doctors and nurses, and sadly for many of us working in the field, when Theresa May's Home Secretary stopped the transfer of all police custodial services across the country to the NHS, I mean, that was really actually, for most of us who work in this field, a devastating blow because there is no consistency of governance. When you have an organisation like the Met Police, which is a huge organisation, there's such variability. There's a postcode lottery within the Met itself as to the nature of care given and the availability of care that may be signposted or safeguarding needs that are there. So it's a lack of consistency currently on top of a really very complex group of patients.
I'll bring you in, John, in a second. So it's an increase in demand, but a change in the nature of the demand, but also a change in the resourcing and arrangement. John, welcome. Thank you for coming. Thank you for coming along this morning again to this building. John, would you like to comment on that point?
Well, there's two. The first one, the initial one about vacancies within the nursing place. I mean, the reality is that our rotas are freely available, and you can see what has been open for the last, I think it's 7 years, because it's all on the computer. And the spaces are relatively few. When you talked about there being 8, there's 9 full-time stations now, and there's 2 additional ones which do you know the way that the setup works with regards to the nursing? There's the 3 and the floating team that will cover, and the 2 at Wembley and Acton will cover. So as far as I'm aware, the number of spaces, vacancies, is really very small, and I'm not sure if it's any different. I would imagine it's actually smaller than the number of spaces that the FMEs have. I mean, the number of times I see the cross-covering.
Yeah, I mean,
of FMEs.
I think the issue is actually it's one of resilience, is that there's enough if nobody's sick or unable to get in. So I don't think there's any in terms of staffing levels, they're better than they have been. I think the numbers are just about what they were. Obviously, the number of custody suites has changed now, but they're similar to what they were in 2013, 14. So I think there's about 64, and there's about 70 doctors
but there's
who
no
provide the work.
There is, resources are very scarce, there's no question about it, and they're not going to build in a situation where numerous people can go on holiday or be sick at the same time. So there will be occasions when there's potentially problems. But I mean, the station that I work in, which is Charing Cross, which I don't know, is it the largest station in? It's
the largest station in Europe.
Yeah,
it's quite
I
big.
don't know if it's still the largest station in Europe, but it certainly was. I mean, it's 2 floors. I work there as a nurse on my own, and I work in an area with an FME who would cover Holborn, who covers 8 cells. So when you talk about resilience, I'm working in a station with 30, 40 cells, but I'm allied with a doctor who's also working, but he's only working on the 8. So there are occasions when nurses will be absent. It's almost inevitable. I'm sure there are occasions when yourselves, a member, your colleague, will not be there, and it's difficult to cover their experience. But as far as I'm aware, the level of care is significantly better than it was in terms of the actual having somebody physically there. And the other thing I'd like to, when you talk about there will inevitably be differences in experience when it comes to nurses who come, but there's a threshold which you would have to cross before you following your interview, before you are employed. And nurses have 4 years training before they are qualified. I think on the last occasion when we had the meeting downstairs, you voiced your concerns about the introduction of mental health nurses. And if I'm entirely honest, I had similar concerns as well. But if you support these people, then there's no reason why they shouldn't work in the environment. When we're given an education budget, which never used to happen, this is a relatively kind of new in the last 2 or 3 years, and the mental health nurses, I think they're stipulated that they have to employ that money initially to increase their skills, so minor injuries, illnesses and such like, to make sure that they're suitably covered.
I mean, I think it's obviously important to understand the different patterns in which we work, and John quite rightly talks about, for example, Charing Cross and an FME covering Holborn with fewer cells. However, what that FME is also doing is covering other stations which may have needs, for example, that custody nurse practitioners have, but more so we may be going out to, for example, scenes of death, to hospitals to do assessments. There's a range of things. So the other substantial difference is the nurse team are employees of the Met, the doctors are not. And one of the issues, and again, I think John quite rightly brings this up, is the question of cover from doctors. So, for example, at the moment, I don't think either Aman or myself know whether or not we will have any rota work next week. The excellent forensic healthcare services staff are themselves struggling because they are short of staff. They've had a very sad recent bereavement of a colleague and friend of many of us. So there are different tensions and there are different needs for the two groups of healthcare professionals who work in different ways. And again, as John rightly says, we're all trained in different ways. All doctors are trained to clinically assess, diagnose and manage. Not necessarily all nurses are. And of course, doctors, there are different levels of skill within those. So the mix of healthcare professionals is an interesting one in the Met, which again, were there to be national standards, and it's a bit of a sort of plea here for support from yourselves to support any move across the United Kingdom to standardise care. Because we have, with our nurse colleagues in the United Kingdom Association of Forensic Nurses and the College of Paramedics, where paramedics are undertaking the same functions across the country, we have agreed standards, minimum standards for each of those practitioner groups, which would ensure that any of the issues that we're discussing would not be a problem.
We get that. I mean, as you say, there's a complexity around this. If you're from the outside trying to understand it, it is quite difficult to understand with the different
I think all the doctors, we know that the future is a combination of doctors and custody nurses. We know that, and it does work well. John and I, we work together, and I'm always reassured when John's on, because I know that he's more than capable of managing the broad spread of physical and mental health problems that we come across.
We have no doubt. I'm going to bring Simon in a minute for his comment on it. So I'm just giving full warning, sir. But let me just intercede. My last point before I move on to Simon, sorry to cut across you, is that we've heard. So John was saying that there are few vacancies. I heard few vacancies in. So my point is really are there though times across the medical family, shall we say, when there are too few staff to handle the demand, you said the rising demand, is there a way of just responding to, are there times when there are too few staff, and there's a question of safety?
We will find out when we start the shift,
right.
Whether there may be a nurse absence that we have
right.
to assist with. So it is a rare occurrence, but nevertheless it does happen, and there is no resilience in the system to try and bring in additional staff to cope with that. We're obviously expected to stretch to accommodate. I think the concern going forward is as the number of 24/7 custody suites that are managed for nurse cover. As that expands to 14, the model is that the doctors will be covering even greater ground. The number of custody suites that are 24/7 run by nurses
and hospitals and other venues
will absorb some of the doctors that had originally been on call. So the total number of doctors covering the metropolitan area will reduce. Now, the worry is that if there is no plan for additional resilience, then potentially there could be a doctor that is stretched over 2 large custody suites, perhaps, and in addition to the responsibilities that we have looking after hospital visits for drink drivers, drug drivers, attending scenes of death, dealing with the aspects of the work that only doctors are able to do, which involves, for example, seeing individuals who've been tasered, also administering Schedule 2 controlled drugs like methadone and Subutex. That comes down to the doctors. We are already stretched, and if going forward there is an additional responsibility in that, we are talking about the worst case scenario, where we're left covering for nurses. Unless that's dealt with, there will be problems.
All right. We're going to be exploring and challenging about resilience later, and certainly in the second part of the meeting. Heads up over there. Right, Simon, I want to ask you your thoughts as an independent custody advisor. You've heard some issues there. How has that impacted on? How's the model impacting on the care from your experience?
Unfortunately, with the area which I cover, which is the northeast, Romford is pretty much out on a limb. I think it's certainly the furthest east, and probably and it covers a very large geographical area. As you know, the Barking, Dagenham, Havering and Redbridge have all been joined in one super borough. But Romford is on the extremities. Now, when Ilford supposedly is closing at the end of May, Ilford custody, that will leave Romford out as extremely on the extremity of the area. Romford, Freshwolf. Freshwolf does have a custody nurse most of the time. I do worry about the doctors being able to get there because of the large geographical area. It is a long way out. I'm not sure what area they do cover, but I believe it's quite a way into London. So if they're at one extremity and they've got to get out to Romford, it's quite a long wait. I mean, I have known of, if it's late in the evening and the doctor gets a call and he doesn't finish before his shift, it gets handed over to the next doctor, and there may be another delay in that doctor getting to that suite.
Have an impact on the safety
Exactly,
of the individuals in
And
question.
it may involve them having to call an ambulance, depending on the severity of the person that's there.
We're going to get some questions about ambulances.
Yeah, I saw that.
Yeah.
But,
So have you finished, son?
yeah, yes,
Okay.
I think so. Yeah.
Just a quick one. There aren't any arrangements, for example, in the case you mentioned of Essex covering, or the other.
I don't think Essex Police and the Metropolitan Police get on particularly well, quite honestly. I very much doubt it. It would be logical, but I doubt it.
Similarly in Hertfordshire or Berkshire.
I have got a national role. There would be no resilience to cover in that way.
Because obviously if you call the police an emergency, you might get somebody from one of the other
The
forces.
ambulance is the first option.
And unfortunately, with the ambulance, that takes 2 officers off the street because they have to accompany the detainee to hospital.
So exploring again the current model, you've talked about the geographic challenges in your particular area, which we understand, but if you just cast your mind to the model itself that we've heard about and your comments around that, is the model itself give you concerns from some of the things you've heard already?
I think 3 years ago it was proposed that there would be a custody nurse in every custody suite, which obviously never happened. Romford had one for 3 weeks, Ilford never had one at all, and then of course the whole plan was abandoned. With the delay, particularly with Romford, I think that there should be a custody nurse available there, because as I say, it is on the extremity of the area.
Well, that takes us quite nicely to our next group of questions, which is around recruitment, numbers of nurses, etc. Caroline will be leading on that section.
Thank you. Thank you very much for your contribution so far and for the round table, which was very, very useful. John, we've talked a bit already this morning about the number of nurses in custody, and if you look back, originally the Met had a target for 189 full-time equivalent nurse practitioners. That then was reviewed down to 139, and under the enhanced model it's now down to 64. We haven't really seen any justification for that reduction. We've already heard from Simon that some other custody suites could do with having full-time nurses there. What's your view on it as someone who's working there at the front line, and are these concerns justified?
With regards to the numbers, I don't know if you. I'm a custody nurse. I'm not management or anything like that. So it's talking from my experience as opposed to.
I wanted to hear, from the front line.
I don't know where these figures came with regards to the 199. There was never any justification. I think it was sold as this fantastic idea, but I don't think there was any research as to why or what those numbers were going to be. There has been problems, unquestionably, about recruitment of nurses. A couple of things have been addressed. Certainly, the number of nurses coming through. I'm now one of the oldest people who've been there. The numbers of nurses coming through is much increased. There was this assumption when I started that we would sell the story of what a fantastic place this was to work, but it never happened because it was lacking in so many things. People were taking a pay cut to come. There was very little possibility of advancement. Education, there was no time with regards to education, so you weren't going to do that. Even something as basic as annual leave. If you came from working in the NHS and you'd been there for a long period of time, you'd have a certain number of annual leaves. When you came to the Met, they started you at the bottom of the rung for pay, for annual leave, for everything. So not only would you take perhaps a £10,000 pay cut, but you would lose a week's holiday. There was very little incentive. The NHS is a fantastic institution. I don't think we treat it with the respect that it requires, and we don't cherish it. But we are benefiting from increased numbers of nurses who are, completely disenchanted with the work environment of the NHS. People are looking at what they are doing and thinking, actually, I don't want to give up being a nursing. It's my vocation. Where else can I work? In actual fact, it's only now being a kind of a story is trickling out. I've seen these adverts in the Nursing Times and Nursing Press of a nurse sitting in a custody cell for years, and I think realistically people have just turned the page. But I think now it's actually making a difference, and the money is comparable, the holiday is comparable, the education budget. The fact that we have £1,000 to, it's directed if there's a need, if during the course of, it's identified by your management, or that there's an area where you feel you're weak, or through our own reflection we find there's an area that actually we didn't realise this was going to be such an issue within custody, then the expectation would be that you would spend that money on, you would find yourself a course that was accredited, and you would spend your money on that course to fill that gap. 64 nurses, the provision of nurse teams in the number of stations, I would imagine it's more of a Met issue. When I think we're coming on to the issue about how the closure of custody suites impacted upon things, which I'd quite like to say something about. If you had designed a system 10 years ago with regards to the number of nurses and doctors and the number of custody suites, I think you would look at it now and think actually it doesn't bear any resemblance to what we have here now. The number of stations that have closed, the number of doctors has been reduced. The number of nurses, the expectations are being reduced as well. But I do think it's improving, I think. And from my understanding, they are now talking about, I think there's a number of more nurses who will start their training. I'm not sure, I think at the end of this month or the beginning of next month. And so a further tranche of nurses will appear as well.
How do you feel in terms of 64 is the current sort of number, and it looks like almost at last we're getting there in terms of numbers. Do you feel that's enough, or do you still feel, because of the resilience issue, if a nurse or two are off on holiday or sick, that actually you need just more than that to either cover additional custody suites or just to give some flexibility?
In terms of knowing if there's a gap, then we know when there's going to be a gap, because I know what I'm working next Christmas, I know what I'm working in 5 years' time, my rota is stuck. If it's about sickness or long-term sickness or something of that nature, then they will cover it. There is a selection of bank nurses, there are agency nurses, there are people who inevitably we want him to do overtime. I think the issue comes if someone goes sick shortly before their shift. And I'd imagine, that's a similar thing for the doctors, although I imagine that you ring a colleague and the colleague says, I'll do you a favour or something like that, which isn't something which we can necessarily do as nurses. I think in an ideal world you would have a spare capacity, but I'm not naive. Money is incredibly short at the moment. They are not going to pay for a nurse to sit on their bottom
Of course.
and do something. So,
But there's potential there to look at the figures again to see whether it really fits the current pattern.
If there's a selection of nurses who can, I think I don't know whether it ever came to anything, but they did talk about perhaps identifying a number of experienced nurses who would they put on a kind of almost like a global floating team, and they would act as mentors if they weren't needed, and they would go and work with people who were a little inexperienced or hadn't been there for a long time or were struggling. But if there was a gap, then they would be. But I don't know what actually happened to that. I don't know whether.
Okay. And what about morale amongst the professionals you work with, the colleagues in nursing? Sounds like obviously the pay and conditions and things have improved and it's more attractive, but how is morale generally?
I genuinely think it's increased.
Mm-hmm.
It's a stressful job. There's no question about that. But I think on the subject of vacancies, that's important, because if you have an appalling shift and you leave and there wasn't anyone there, then that was going to be an issue. And I think there were stations where they were only half full, and I think you get that prolonged period of time where you're, I wouldn't say despair, but heading in that direction. But having a full team makes a massive difference. Feeling somewhat more valued. I hesitate to blow my own trumpet, but my understanding, the police like having us there. They are very welcoming, they are protective, they're supportive. I see myself as a nurse who works for the police rather than a police staff who happens to be a nurse. But there is a sense of team that exists. There's no question. I think morale has improved now. I think also actually management has improved, and it certainly 5-6 years ago we were very isolated, and there was no contact or support from management, and that's changed a lot as well. We're far more included in what's going on.
Very good, Tim. You mentioned the education budget. Is there any other training and support that is needed for professionals such as yourself working in the custody suites?
So we have the education budget, which we allocate ourselves. We have twice a year we have development days, and so if there's change in legislation that impacts upon us, or if there's there's been a near miss or an incident that's required that we need to be more aware of something, then that would be brought up on those occasions. And I think actually, Dr. Ranu, on the last occasion you talked about the fact you felt that we would benefit if we had study days together. Was that you? And we used to have those when I started. We used to go to New Scotland Yard, and it's fundamentally what it built trust, I think, probably more than anything else. And that's something which I think is potentially missing. A lot of the nurses will only speak to a doctor if there's a problem, and they will not see a face. Today there's a lady who's covering my shift, and she started in October, and she says she hasn't seen a doctor since she started in October. So it's very difficult.
Speaks to the person.
Yeah, she speaks to them on the phone. But it's very difficult to build trust if you don't have a face-to-face contact, I think. We would benefit from having joint education like we used to do.
So to our FMEs, do you think that, in terms of as it's a new team approach going forward, that actually you would benefit from having sort of joint sessions where you can work together?
I think the problem we're hitting is, and John has reiterated all these ideas have been talked about. They've been talked about in this forum previously, and we as doctors and nurses and paramedics and mental health professionals, we work everywhere else as multidisciplinary teams where we talk, we meet. That's normal. That's what healthcare professionals do. I made a comment, I think, when I spoke here before, that there almost seemed a strategy to keep us separate. I know, roundly criticised by one of the senior police officers at the time, but it is something that I completely concur with John on this. In the past, I'm thinking, 10 years ago or more, we used to have the joint teams. It's a decade or so ago, we used to frequently have these. What we've had to do as doctors, because we don't have the support of education budgets, because we're employed, or we're employed contracted in a different way. But we have 3 monthly audit meetings where 20 or so of us will get together on a regular basis to discuss issues. But that's how healthcare professionals generally work, as multidisciplinary teams. That's how they're most efficient. And I agree with John that there are many of my nurse colleagues, I work predominantly in the northeast, in Wood Green and Leighton, who I've had many conversations with, but I haven't actually physically met them, and the conversations relate to care of patients. So I think all of us would concur multidisciplinary working is the way forward, but it's been the way forward ever since we discussed it in the past. Okay. It's not a revelation.
Lovely. We'll pick that up with our next panel. Lovely, thank you.
Okay, thank you. We mentioned earlier about ambulance call-outs and the issues around that, and the significant increasing number in call-outs. We've got some questions around that, Susan.
Yes, first question, please, to our two doctors. What circumstances would you expect to see an ambulance attending custody?
So it would be nice to break down ambulance call-outs into what you could see as necessary and unnecessary in terms of the actual clinical need versus an individual who may be reacting adversely to having been detained and reflecting a collapse, for example, that isn't related to a medical condition. So ambulances are obviously called out for episodes of detainees collapsing, being unconscious, having suffered perhaps a fit, or having, before coming into custody, having sustained a head injury perhaps. Sometimes there are other medical factors, perhaps diabetes, where a collapse may be possibly related to a low blood sugar episode. In addition to that, we've got individuals who may need to go to hospital because they've suffered injuries where it wasn't immediately apparent that they could have sustained a fracture, and they need to go to hospital for an X-ray, for an investigation. There are the obvious acute medical scenarios of chest pain, where there may be a cardiac underlying cause or other medical cause. But we are at the mercy of individuals who may not have any underlying conditions, and in view of a risk-averse philosophy, I think, that goes across custodies, the custody staff's hands are tied when anybody does say that they've had an episode of chest pain, or perhaps the other trigger for a reflex referral to hospital is if they say they've swallowed drugs. So there are all sorts of contexts where an ambulance will be called. Whether there is a member of medical staff present or not doesn't always make a great deal of difference. There are obviously situations where a member of the medical team on site can intervene and suggest that the police may have triggered a call out for an ambulance, but when the individual's been assessed, the member of medical staff may well say, no, this is obviously nothing that needs an acute referral to hospital. But more often than not, we are finding ourselves faced with some uncertainty as to whether there could well be a medical condition, underlying medical condition, that does need hospital attention. And in the interest of patient safety, it is the right decision for an individual to be transferred to hospital in that scenario.
Got anything to add to that? That's pretty comprehensive.
I mean, I think it's important also to and I'm sure the committee is aware, but there is a trend in some settings to try and believe that police custody suites have the capability of being mini hospitals, but they're not. There's no facility for diagnosis or investigation, and so in authorised professional practice, which overarches how police approach them, there are two things. Simply, if somebody can't walk or talk, take away medical issues such as possible myocardial infarction, then people shouldn't be in hospital, shouldn't be in a police station, and they should be transferred to hospital. And I think that's, as Aman says, a very safe thing to do. The problem that we have, the question is how what we think should mean that people are referred to hospital. The problem is what we don't understand, we don't have the figures for, is actually when ambulances are being used. Now, I had a meeting in November with the National Association of National Ambulance Research Steering Group, because one of the studies that we'd like to do is to look at all the data for call-outs by London Ambulance Service to police stations in London to determine the nature and outcome of those call-outs, because we're aware, and we knew from figures in 2018 where there'd been almost a doubling of ambulance call-out as a percentage of detainees coming through custody, that we were putting stresses on the ambulance service. a personal view, but I can't support it because there is no evidence at the moment to support it, is that those call-outs have increased. What we don't know is why and what the nature of them are. And so that is what we hope is ongoing research sometime this year to determine the nature of those call-outs.
Okay, thank you. My next question falls straight into that, and perhaps I can bring our police officers into this. It has doubled in the last 4 years. Have you any ideas of the reasons for that?
I would say that it's potentially because the increase in healthcare provision that we have got means that potentially more serious medical conditions are being identified, and that in turn is leading to ambulances needed to be called. I'll just pick up on something that Dr. Payne-James has said, that I completely agree with him in that our medical rooms, the assessment rooms, are only that. They're assessment rooms, they're not treatment rooms. Probably the most technology that you've got is a blood pressure monitor and an intoximeter. Nothing more than that. So often the London Ambulance Service, or an ambulance service, is required so that they've got the ECG provision, and because an ambulance is called doesn't always in turn mean that the detainee will need to go to hospital. It's just that the ambulance service have got mobile technology that they can bring into the suite to assess a person to determine whether or not they do need to be hospitalised. And then picking up on further points, if a detainee is identified as having broken bones, then my view is that an ambulance shouldn't be called for that, because that's not a medical emergency. A police vehicle could be used to transport a detainee to hospital under those circumstances. But therein lies another problem, because custody suites don't have their own fleet of vehicles. They're relying on the emergency response teams policing out on the streets, and they are as stretched as everybody. So therein lies another problem. We shouldn't expect a detainee to have to wait long periods of time to be transferred to hospital. So sometimes a measure will be to call the London Ambulance Service. Similarly, if a person is sectioned, the protocol at the moment is that they would be transferred to a mental hospital, for want of a better expression, but using an ambulance, and that's a bad use of resources. But that is the protocol at the moment between the MPS and the London Ambulance Service.
That needs to be looked at as well, but I assume you'd find the data very interesting if that could be made available, just to see what the underlying issues are. Okay, you got anything else to add?
I can give you a flavour of a shift that I worked on Sunday, where a young and relatively fit 20-year-old man went to hospital by ambulance 3 times in 24 hours. Originally because he'd been involved in a road traffic accident, and he was checked in hospital. He returned to custody, complained of a prolonged headache, went back to hospital for a CT brain scan, came back to custody, and then went back to hospital with chest pain. And he was actually fit and well.
On those occasions, of course, 2 police officers had to accompany him as well, and the ambulance service. Right.
Again, that is an abstraction of police officers from the streets, because we wouldn't send our own staff from the custody suite into hospital. Just picking up on the risk-averse issue, it's a very fine balance really between where risk aversion comes in, and the advice we would always give to custody staff is that if a detainee appears to be feigning any kind of illness or injury, you should err on the side of caution and treat them accordingly, whether as a medical emergency or not, but certainly call for a healthcare professional. There was a case in another force a while back, a chap called Christopher Alder, who had been arrested in the street for fighting. He'd sustained a head injury during the fight and had been taken to hospital. He continued to fight in the hospital, and the hospital didn't treat him. He was brought back to a custody suite and is basically laying on the floor. Custody staff are standing around him, probably about 6 police officers, and the person appears to be in difficulty with his breathing. The police officers are kind of alluding to the fact that he's put it on and he's feigning it. For all intents and purposes, Christopher Alder died in front of them at the time because they were under the impression that he was faking it, and if they'd have erred on the side of caution, which technically I suppose is risk aversion, they would have called an ambulance, and Christopher Alder may not have died in police custody. So it's a really fine line around risk aversion, and we can't tell custody staff not to be risk averse. A death in custody is catastrophic, but a death in custody that could have been prevented is even worse.
Has anybody got any other comments on it?
I think it's just, I mean, when you, I think you alluded to that, when you talk about ambulance, you seem to be using it almost interchangeable with hospital, and I really think that there are so many things that could go to the hospital that do not need an ambulance. And so, you know, hand injuries, facial injuries, I don't want to be, you know, the person who causes someone to be scarred for life. If someone has a cut on their face, yeah, then I believe that they should get the, you know, the best treatment at the most appropriate time. But they do not need to go to a hospital in an ambulance. I think, you know, there should be some sort of flexibility where the police can take this person. Because the other thing you talk about, the number of call-outs. I mean, having spoken to ambulance crews, call-outs, you know, they almost ignore it. It's kind of bread and butter. It's what they do. What they get increasingly frustrated about is the time that they are spending in custody waiting for the escort to turn up. And I had before Christmas, where I wanted to send somebody to hospital. The ambulance came, they waited about 2 hours, and then they left. And then the escort turned up, and they said they would stay in the building. We had to recall the LAS, and I think the whole process took about 6 hours to get this person, which is, you know, absolutely inexcusable. And with regards to risk aversion, the police are, you know, they seem to be, there's increased education, and I think when I started, police weren't aware of the risks. Actually, they assumed that everyone who came in drunk was like they were in their 20s when they went out and got drunk and just, yeah, ultimately went to sleep in their bed, might have thrown up, and then got up and went to work in the morning. They're far more informed about the potential risks, and so they're far more likely to call an ambulance now than they would have done. But in the past, I think you would have seen far more problems and far more, you know, potentially death in custody.
Yeah, I mean, I think we also have to, we talk about, as it were, almost the misuse, or perhaps the inappropriate use of ambulances, but there is the other side of that is that increased workload does mean that when there are people who desperately need to go to hospital urgently, or you need somebody blue lighted, that there may be unreasonable delays then. So it's a real problem. Having said that, we had a patient just last week who was actually sitting in the front office of Bethnal Green Police Station and had, for some reason, taken a massive overdose of methadone, and London Ambulance Service were there within three minutes to get him to hospital. So this is not being critical in any way of London Ambulance Service. It's how the Met somehow manages the appropriate use of ambulances, minimises the demands on the police personnel who shouldn't be extracted from other duties. And it's a really complex problem. But I don't believe, until we've actually got the evidence base for that, what are the numbers, what are the means, why are they referred, and what was the outcome, I think it's very difficult to draw any real conclusions about how it should go forward.
That's a fair enough comment, thank you. Thank you, Chair.
Yeah, yet again another complex case balancing that risk adverse against the demand. So again issues around that, and we'll be returning to deaths in custody, some later questions. We're turning now really to children and vulnerable adults in custody, about the numbers and the care that's required for appropriate adults. I think we've got some questions, and Andrew, you're leading.
Thank you. Sort of a general question to start off. What progress have you seen in the treatment of children and vulnerable adults in custody? We'll start with Andy.
So in terms of children that are charged and remanded, obviously there is a statutory obligation for the police to secure or to arrange alternative accommodation for juveniles. And we have seen a great improvement in that process in terms of local authorities appear to be more able to provide the accommodation for us, whether that be secure or non-secure, whereas historically it always seemed to be a kind of a paperwork exercise that we knew we had to contact the local authority to arrange accommodation, and they would always tell us that there wasn't any available, and that the process ended there. But now local authorities appear to be much more obliging. Obviously that is only for juveniles who are charged and who are remanded, so not given bail.
Can I put the figures to you, Andy, because they don't seem to support that case.
Okay.
We were told in January to January this year, i.e. the year, 420 requests for non-secure accommodation, 394 requests for secure accommodation, 50 were in the care of local authority, 48 non-secure, 2 insecure, and they're in Leeds and Manchester. So it looks as though it's still quite a big gap.
So part of the issue there is potentially custody officers asking for secure accommodation when secure accommodation isn't already needed. There's no secure accommodation anywhere in London or anywhere within the N25. I think there's only 6 places across the country, and they're widely spread out. So quite often, if secure accommodation was available, it's not going to be practical to get the person to, say, Durham and back in time for a court appearance the following morning. So part of the issue there is custody staff asking for the wrong type of accommodation, asking for secure accommodation when non-secure accommodation would generally suffice. And there's steps, we've put plans in place now where if a custody officer requires or requests secure accommodation, that is overseen by an inspector who will mediate over whether or not secure or non-secure was needed. More often than not, it would be non-secure accommodation, which is much easier to provide.
Even looking at non-secure, it's only about an eighth where you actually get the non-secure provision.
As I alluded to earlier on, previously it would be 0. So there has been an improvement, even albeit a small one.
A small one, yeah.
Yeah, but it's early days. You know, we've only recently been working more intensely with local authorities to try and work better with them to include their provision of alternative accommodation.
What about vulnerable adults? Have you seen any change there?
Okay, so that is a really difficult nut to crack. So local authorities have a statutory provision to provide appropriate adults for juveniles, but there's no such provision for vulnerable adults. And similarly, there's no such requirement to move a vulnerable adult to alternative accommodation when they're charged and remanded. So I know there's work going on in the background in relation to trying to improve the provision of appropriate adults for vulnerable adults, but it's a tough nut to crack nationally, I would imagine.
Yeah, well, I'll come back to that in a minute. Andy, do you want to add anything about children, or Simon about children?
Well, I can mention some of the developments that are going on with children in Liaison and Diversion. So Liaison and Diversion, you should probably know, is funded by NHS England.
I think you're going to get separate questions on Liaison and Diversion.
Yes. So, but part of that provision is to provide an all-age service. So increasingly we've been asked to employ specialist workers in youth offending services. So each borough now across London will have a specialist liaison and diversion worker in a youth offending service. So there will be links with the police for that.
Simon, do you want to add anything about children?
Sorry, me. I mean, the problem, one of the problems is obviously with children. Very often, obviously, the parents should be contacted first of all. Very often, the parents are not suitable for one reason or another. They may well be involved in the offence. I do see quite a lot of children who are involved in domestic abuse, where they've assaulted a mother or father, and obviously the parents then cannot be used. And the local authority, generally speaking, the local authority do not come up with anybody to act as an appropriate adult. Now, at the round table, I did suggest something which Caroline picked up on, that there should be a London-wide, because there's a disparity between what the local authority is supposed to provide for juveniles, which they don't, generally speaking, and nobody having responsibility for vulnerable adults. We have a scheme going in Redbridge, which is about 12 or 14 volunteers who do it all voluntarily. I won't say we're available 24/7, but we can be called on 24/7.
That's for adults, is it? Or
Sorry?
You said that's for adults or for children, or
it's for
both?
For anybody. It's, if an appropriate adult is needed, it's for anybody, basically. And I would think the majority of people, probably 60% of the people I see as an appropriate adult are vulnerable adults rather than juveniles. But we have this scheme going in Redbridge, which seems to be working quite well. And what I've thought of is that there should be really a London-wide, which is what I suggested at the round table, a London-wide scheme going, borough-based. So you're just using local people, because I don't want to go over to Hounslow as an appropriate adult. I'm quite happy doing it in the local area, which is, I use public transport, so I can't get very far in the short time that is needed for me to get to custody. But if you have a London-based, a London-organised, borough-based scheme, very similar to the custody visitor panels, all volunteers, they're doing it because they want to do it, they're not doing it for the money. And I think it would work very well. And there are plenty of people around. For my sins, one of my other roles is a trustee for a charity down in Havering, which is a volunteer centre. And it is amazing the number of people who are prepared to volunteer for all sorts of things. There's a willingness there in the public to volunteer to do this sort of thing.
I mean, is part of the problem that people don't know actually how to do it, or
I
the shortage, or is it a bit publicised? No, volunteers being added.
I don't think it's publicised. I don't think people are aware that this role could be done. I mean, it does need some sort of publicity, obviously, to get people to sign up for it. But we didn't have any trouble in Redbridge getting 12, 14 volunteers to do it. Some of whom are custody visitors as well, because it's a very complementary role, I feel. You know, as custody visitors, we're going in, we're dealing with 12, 14, however many people in their welfare. But as an appropriate adult, you're going in to deal with an individual to see to their welfare and make sure they understand everything that's going on. But I do not think it would be a problem recruiting, quite honestly. And I think it would be... It's very piecemeal at the moment. I spoke to the custody manager at Romford yesterday. They use Appropriate Adults UK, which is a paid scheme, for which the local authority pay, apparently. Another anecdotal story that I got from a custody officer yesterday. He was, I can't remember which borough he was involved in, but he had a juvenile arrested in, living in one borough, arrested in another borough, taken to custody in another borough. Which local authority was going to deal with him? None of them. This is why I say, if you have a London-wide voluntary scheme, we don't mind which borough they're from. Yeah, we don't mind if they're juvenile or adult. We will deal with them. You know, we're made aware of this, obviously, at the beginning of the process, that we volunteer for it. But we're not going to be nitpicking about which borough they're from or whether they're juvenile or adult. I mean, I've had some quite unpleasant, nothing violent, but unpleasant experiences with some people. But I've had some very pleasant experiences with people as well.
Andy, I mean, I understand at the pace that it's an obligation, a duty to contact an appropriate adult for vulnerable adults. But doing what Simon says,
the police are not allowed to pay for it.
Oh, right.
That's the problem. It's a rock and a hard place there, so it has to be.
So presumably, Andy, there are problems if you can't get an appropriate adult. I mean, how often does that happen? That you
Undoubtedly, and that is the fundamental problem that we face daily. There has been occasions as a custody officer when I've popped across to the local library opposite the police station and said, can you just come into the police station and help us deal with this person, please? You know, it's really difficult to crack. But can I just throw something out there for potential discussion, speculation, possibly even development? So our custody manager at Holborn, Inspector Mark Woodward, is also the Met Detention Lead for Mental Health. So he's been looking at all of the different aspects, including appropriate adults for vulnerable adults. And he's come up with a fairly radical suggestion, which would involve a legislative change in that where a vulnerable adult has been arrested, has asked for legal advice, and we've arranged a solicitor for them, why do we then need to arrange another person to come along and represent their needs and their welfare? Why can't the solicitor, in isolation, act as a legal advisor and an appropriate adult? And I understand that it's fairly radical, but I definitely think it's worth giving consideration to. He gave an example of a person that was schizophrenic. Schizophrenia was being well managed. He'd been booked in, had asked for a solicitor. Solicitor had been arranged without delay, promptly. But because of the legislation at the moment, an appropriate adult was required. The detainee was left waiting for up to 3 hours solely for an appropriate adult to attend so that he could be interviewed. Well, the solicitor could be there to give legal advice and to make sure that the detainee's welfare and all of their interests, and make sure they understand everything that's going on, all of the roles that the appropriate adult would play. A solicitor could do that. I understand, as I say, it's radical, but I certainly think it's worth consideration.
In theory, I would agree with that. I think it's a very good idea. But why do you need two people, two adults, for a vulnerable adult? The only problem is, would the solicitor be prepared to wait around to do samples, to maybe do a COSART test, would they be prepared to do that? That's the problem. Where somebody has to be present for all those processes.
Another issue, it's actually professional conflict, is that the role, you can't have a dual role, because their role is obviously to defend their client. What I think Andy's quite right, and Mark's right, you need to think outside the box. And I don't know whether the National Association, the National Appropriate Adult Network is involved or has been discussing with the Met, but I think there are two concerns. Number one is the non-availability, which I think we're all agreed on, of appropriate adults. The other thing is, we're talking about vulnerable adults. The question is, who determines whether they're vulnerable or not, and what are those different types of vulnerability? There's the clear ones, such as, for example, somebody with a patient with schizophrenia or whatever, but there are many others, aren't there? And with an elder population, questions of possible dementia, learning difficulties, things like that become even more complex.
It's very subjective, as Dr. Payne-James has said. One custody officer may think, no, this person is okay, he understands everything that's going on, he's answering questions appropriately as part of the risk assessment, not as an interview, and will consider this person doesn't need an appropriate adult. A healthcare professional may say they do need an appropriate adult, or another custody officer may say that they need an appropriate adult, but it's very subjective. For somebody who has got depression, it's a mental health issue, it's being treated, they're medicated for it, it's effectively made them normal. Why would they need an appropriate adult? But the Code of Practice says at the moment that if they've got a mental disorder or mental disability, then an appropriate adult should be called. And if there's any doubt over whether an appropriate adult is needed, then one must be called. And therein lies the problem.
The problem is right enough appropriate adults to go around.
Exactly.
That's
the
ultimately
legislation hasn't kept up with the demand.
So if we get hundreds more appropriate adults, then the problem you're identifying would disappear.
Yeah.
And partly it may well be advertising the fact that we need them and what the job involves and what the role is.
Sure, the majority of the public aren't aware that there is such a role, quite honestly.
I think we may be able to help there possibly. Okay, we'll probably take some recommendations. So, leading again on the subject of vulnerable adults, it's great, Andy. Obviously, who looks after not just Westminster, other boroughs, which you're talking about. Sian, you've got some questions for
Yes, so my questions are about liaison and diversion. Obviously, they overlap slightly with the issues of who needs an appropriate adult, because they're, if I'm right, intended to find people who have vulnerabilities, who need support in custody, and perhaps divert them to somewhere more appropriate if they shouldn't be in custody. Can you explain that role? And also, you're from Westminster. These are commissioned services from the NHS. Can you explain how it's organised as well?
Okay. So liaison and diversion has been around for about 20 years. It started off in magistrates' courts and was called court diversion, and then expanded to police custody. After the Bradley report, which came out, I think, in 2009, funding and services were kind of developed to cover an all-age, all vulnerabilities, and I think somewhere in there was all hours model of liaison and diversion that was going to work with courts, police custody, youth offending services, and develop a pathway. In London, there are, as far as I understand, 5 NHS providers covering all of London. I work for Central and North West London NHS Foundation Trust. We cover 5 boroughs: Westminster, K&C, Hillingdon, Harrow, Brent. Is that 5? Mm-hmm. Of which I think there are currently 5 police custody suites. They're all, they are closing, and they're amalgamating in certain areas, and I'll talk a bit about that. We don't work all hours. There isn't enough capacity in the system for us to work all hours. We work in some of the custody suites. Charing Cross is one of them, where we work 7 days a week. It's primarily a 9-to-5 service. Occasionally, if there's enough capacity, we can expand it to 8 o'clock in the evening. We are almost based in police custody because we've been offered offices, which didn't used to happen until quite recently. So until recently, we were always visitors that would come in. Now, all the staff that we employ are police vetted, so they can come and go in police stations. We have, through an information sharing agreement, access to a data system called NSPIS, I think it's called, where we can enter data. And between all certainly the mental health trusts within London, there are information sharing agreements, because you'll be aware that each trust has a different clinical data system and you don't always get access to each other's systems. The liaison part really is to, we probably see about 20% of the people that are in police custody 9 to 5. We don't see them all. The referrals tend to come through people like John, the custody nurses, the custody sergeants, the FMEs. The bulk of the work still seems to be people with serious mental disorders. There's been no decrease in the numbers of people with serious mental disorders who are being arrested. The cases are often very complex because they're linked to personality disorder, they're linked to addiction problems, drug and alcohol problems. But we are in there 9 to 5. We see a range of people. We also have staff based in youth offending services who will follow up people, young people that are seen in custody, but increasingly young people are now seen in other venues as part of the, I think it's called Caution +3 or voluntary attendance. Some of the issues that have been raised that cause us some issues or some problems is the centralization of police custody, because a lot of health services and social services are borough-based, and there is often this discussion that goes on about which borough is responsible for someone who's arrested in one, taken to a custody suite in another, but actually belongs to a third borough. That's not just about who's responsible for providing the appropriate adult, but it's also who's responsible for providing the approved social work service, or who's responsible for providing a hospital bed if someone needs to be admitted. Last year in Charing Cross Police Station alone, which is one of the larger ones, we were involved in 148 Mental Health Act assessments, which resulted in detention under Section 2. And often, particularly in Charing Cross, the problem is that people are brought from different London boroughs in there, but often the people are not connected to primary care services, are homeless, or have come down to London from other areas, and that often adds to the delay of arranging services and transport. And that might account also for some of the call-outs for ambulances, for people often being taken miles to their home areas.
The Charing Cross example is quite an interesting one. So that means that basically lots of people who come in there, because they don't have any other connection, end up being sort of adopted by your service. And does that mean also Westminster Council social services take them as well?
So Westminster Council has found that it is now providing an AMP service for people that belong to or have been brought in from other boroughs. And I think that's becoming quite a strain on their service. It used to be that the local hospitals could provide emergency beds, hospital beds for people with mental health problems, and then move them a few days later. But because of the closure of some of the hospital beds, people now wait in custody while negotiations are carried out with other boroughs and other parts of the country about who will be responsible for these people.
Okay, and you mentioned before that there's a specialist liaison and diversion worker in the youth offending service in each borough.
Yes.
So does that mean also that do they come to Charing Cross from the different boroughs where they're young?
When a young person is brought into Charing Cross, now the services have only just developed, so the plan is that they would go into Charing Cross and see young people, and the important bit is the engagement at an early stage with someone, and then they would follow them up. But I understand that less and less young people will be brought into custody and dealt with through the caution +3. So we would have to look at where, liaison with the police about where we would send the workers.
Okay, can I ask about the diversion part of what you're talking about? Because it seems like you were just saying there are issues with diverting people into healthcare, if that's where they needed to be more appropriately. How many of the people who should be diverted do you manage to successfully send on to other services and other support?
Diversion isn't just putting people in hospital beds, it's connecting people to primarily community mental health services, but also into other agencies and charities. There are many examples where working with the CPS and the police, charges will be either held back or dropped if someone can connect to another service, and it looks like the risk is manageable. But increasingly, the number of people that we're asked to see are not only are they quite unwell, but they've committed quite risky offences. So there's often they'll finish in custody and then move on to court, and then it's usually a court decision about diversion, and that's often using either the Mental Health Act or probation orders with community orders attached.
So my question was really, does the availability of other services limit your ability to do diversion? One of the things that the Health Committee here in the Assembly has looked at before is the capacity of community mental health teams, for example, which might be limiting. Or do you say that it mainly goes on to the court to decide that sort of thing?
I think it would mainly go on to the courts to decide that. With community mental health services, which are general services, they are still very cautious about taking what they consider to be forensic cases that have come through police custody. There's always a great deal of concern about risk. So often one of the things we have to do is reassure them that risk can be managed either between them and jointly with another service like probation. So often it's better that someone goes through a court service and then any risk in future is managed by joint services.
My final question is, you described some improvements in the way that your service works within the police, things like getting officers. Are there any remaining barriers to effective working with the MET that you would like to highlight?
I suppose we would encourage the police to provide more facilities, better offices, better connections through Wi-Fi and using laptops. That's probably the only thing we'd encourage them to do, yes.
Okay, thank you.
Okay, thank you for that. Last question is around a subject which we've touched upon already. It's a very grave subject of deaths in custody, 16-17, 3 deaths plus 4 suicides. We touched upon that subject, but Unmesh, you want to ask a question on that?
Yes, thank you, Chair. Sergeant Watts, you told us earlier, and I quote, death in custody that could have been prevented is even worse. So where are we now today in terms of the Met's ability to learn lessons from deaths and near misses in police custody, and particularly in light of the Anglione's report back in October with some 110 recommendations? And my question is to all of you, but if I could start off with you.
Okay, so firstly I'd like to get it into context that death in custody in a police custody suite is still thankfully very, very rare. So we were averaging around about 230,000 detainees a year. We've dropped now to around about 195,000 detainees, and these people are very vulnerable, chaotic lifestyles, drug addicts, alcohol dependent detainees. Our last death in a Metropolitan Police custody suite was in 2016. So death in custody in a suite, as catastrophic as it is remarkably rare, considering the clientele that we deal with. In terms of learning, obviously whenever there is a death in custody, there is an inquest. If necessary, we'll be given a prevention of future death recommendation. Generally, we can anticipate what that may be, and we will always implement steps to add improvements prior to getting that PFD from the coroner. Aside from that, though, there is also successful interventions. We tend to err away from the terminology of near miss because it's got negative connotations to it. We prefer to call it a successful intervention. That way we would prefer, staff may feel more inclined to report a successful intervention because there's been a success rather than a near miss, which got negative connotations to it. So we have a process for any incident, whether it be a search failure or a medical issue, anything that could have resulted in the death or serious injury of a detainee or a member of staff is reported via members of my team. The matters are investigated, and whenever necessary, steps are put in place to improve the steps that we would take in handling those procedures.
I mean, I may be wrong, but the briefing note that I have in front of me, as I read it, I understand that the language, the use of the word, the report of near misses is actually terminology used by the Met Detention's business improvement team.
It's me, but
right.
it's
so,
that's wrong.
So you're the authority, fine. Okay, so
it's a successful
yeah, I accept what you're saying. So if I could move on to you, Andy.
Deaths in custody and deaths following custody, if we've been involved in any of the individuals that have died, we are also party to any investigation that the coroner might have, and so we input information into that.
Fortunately, I've not had any experience of death in custody at all. I do know that I have observed the booking in process, and I can assure you it's a very, very thorough risk assessment. You know, the custody sergeant particularly will not take a chance on anybody. If it's a question of removing laces and belts, they will do that. At the end of the day, people can change like that, so you cannot guarantee. But they'll be observed. If there's any doubt, they'll be on constant observation, which again will very often mean taking an officer off regular patrol duties. But they will do observations through the wicket on 15, 30, 60-minute intervals. I think it's regularly it's 30 minutes, I would think, is quite normal. That's all as I say, I've had no experience of it, so I can't really comment any further.
So sorry, just to pick up on something that Simon's just said about removal of belts and laces, etc. There's an implication there, I think, that it's to prevent detainees from self-harming or attempting suicide. But just to add that of any of our deaths that we've had in the Met in custody, none of them have been suicide or self-harm related. They've all been medical issue related.
Quickly, John, any observations?
I'm trying to think. Following any investigation, if there was a need, then it would be addressed, and they would instigate some sort of training or education program. If anything needed to be highlighted, then that would be done. But realistically, I don't think I can add any more, to be honest.
I mean, we're going to be asking the Met MOPAC very shortly about the more strategic demands and questions around. Did you want to add briefly, Jason? Or
Can I just say, I have quite a lot of experience in deaths in custody, both on behalf of what was the IPCC, is now the Independent Office of Police Conduct. One of the issues is that a death occurs, it is not always clear what that lesson is, and there is a danger from taking a death, looking at the immediate circumstances around it, and without it having gone, as Andy says, through the inquest process, the IPCC process, that points may be missed. The problem is that the outcomes of most inquests for death in custody on research we're just completing is 4 to 5 years after that death. So you have this huge time gap between when the clear lessons can be determined. What I do think is that there should be a multidisciplinary review of any death, and the deaths in custody that we're talking about, the ones that are probably most significant now and should be of most concern to the Met, are deaths post-release from custody, which then brings in the questions, how do you assess people pre-release from custody? And I think that's a big concern for all of us, but I would emphasise that I think that you should have a multidisciplinary involving doctors, nurses, mental health teams. I see the independent custody visitors and others around the immediate circumstances to try and see whether there are some immediate reasonable and rational lessons to learn, rather than knee-jerk reactions determined by 2 or 3 people thinking, oh, this has got to be done.
There's no doubt that the safety net that catches level of risk of individuals who go on to die in custody or potentially die in custody, that safety net is much broader now than it's ever been. And there are several reasons for that. The risk assessment, as was mentioned, the formal risk assessment of any detainee who comes into custody picks up on medical conditions, drug and alcohol problems. Alcohol particularly, the risk assessment for that has developed extensively to establish whether individuals are physically dependent on alcohol, which obviously is a huge factor in risk of death. The other huge issue in avoiding deaths in custody is ensuring that the clinicians, the doctors and nurses, have got the general competency to pick up, for example, a spleen that may be slowly leaking blood. That takes quite a considerable range of experience that's desirable in the medical and nursing role, and obviously that also involves adequate training at the outset, and again, we were at a stage where the Faculty of Forensic and Legal Medicine had started to become involved in assisting in the training of doctors and nurses coming into the Metropolitan Police. That situation, I understand, has changed, and I don't know who's going to be providing that training now, but it's going to be crucial that anybody coming in to forensic work, particularly if they don't deal with a great deal of physical illness, clinical illness, those individuals really do need to be brought up to speed in assessing those sorts of factors.
Okay.
Can I ask one final question? It's just that of the recent cases, and I'm sure this is probably true going back as well, some of them are suicides after being released. And that seems to me like that's a different issue than missing the diagnosis. So many people go through the books who have mental health problems, who might be at risk of suicide. But is that an issue with subsequent care and being able to refer them on to other issues? Is that being looked at in connection with these deaths?
I risk sounding like a broken record again. That's another difficult nut to crack. To prevent a death in custody is relatively easy with all the control measures and all the safeguards that we can put in place, because they're under our care and control. But once they leave the custody suite, and they're effectively not under the care or control of anyone else, maybe for a period of time when they can get help, then free will kick in, and their person will take their own life. So whereas I alluded to deaths in custody are relatively low, deaths following release have dropped off currently, touch wood, but we were averaging around about 1 a month. Generally for the offences are domestic abuse related matters, sex offences, and drink drive related matters are the highest amount where detainees will go on to take their own life. There is a pre-release risk assessment that's conducted for every detainee when they leave custody. There is an agency referral leaflet that is given to every detainee when they leave. Those agencies that are relevant to detainees should be signposted on the leaflet. Really, it's about self-help. We do have a relationship with the Samaritans, and the detainee can we can pass on the detainee's details to Samaritans, and Samaritans will call them. They'll make, I think it's about 3 attempts to call them, and then after that, if they don't get any joy with them, then that process will stop. But yeah, ultimately, it's about free will. When they're not in our care or control anymore, there's very little that we can do to prevent them taking their own life.
So I just think where liaison and diversion services are involved with an individual, then it's important that any information that we have is passed to the custody sergeant at the point at which they may be released, so any decision can it can help determine that decision. We have been involved in some cases where people have gone on later to commit suicide, and we've been asked to contribute to any inquiry. So we learn lessons back from those. There haven't been that many because we don't always, we're not always connected with them, and people can go on months and months later.
I think the problem is that certainly the IOPC and coroners have particular interest in people who have died post-custody release, currently up to a month, sometimes a couple of months afterwards. And every contact, whether it's from a designated detention officer, custody nurse practitioner, forensic medical examiner, every one of those contacts will be looked at to see whether opportunities were missed. So I think it is something that, as the Equalities and Human Rights Commission raised in a report in just, I think, the end of 2016, it's an area that is not going to go, it's an issue that's not going to go away.
Okay. Good. Well, thank you for that. We've finished that round of questions. Really do appreciate your time. We'll be capturing those and framing some recommendations around that. So, again, thank you. Welcome to stay for the next session, but if not, have a good journey. And we're just going to have a 5-minute switch over of nameplates, etc.
Thank you.
Guests can join us.
Very well. Great. Yeah, family.
Yeah. What happens to the rest outside?
Yes, that's not really picked up on it.
One of the students actually had been more or less on the scene.
I can't remember.
I was a bit hesitant to bring this up.
Yeah.
This already filled.
So I've got a 15-year-old mum who I was there for the World War. And I've got a 12-year-old boy who's on camera.
Is that Trump?
I struggle with. He's not even a teenager. Oh, no, he's the sweetest, kindest, loving boy.
Yeah.
It's before custody, wasn't it?
And the one in New York, I think, was as well. Those are straight.
They are great.
I remain
Take with them. Still going on.
What's the meeting you had? What's that?
That's the notes at the end. So Appendix 3's got some notes on it.
See, it would have two numbers come out.
I don't know. I mean, my phone was stopped and I got a new phone and it had a SIM and then I transferred it to the system. But it's not happened properly.
Right.
So it's still
So you're still thinking
its old
about.
number. It's really
John, nice to
stressful.
see you.
Oh, good.
I know, and I can't.
I
I
have
haven't
trouble
got
with one
some,
number.
I haven't had time to queue up in the shop. I've tried to sort it by phone and web chat, but it's never worked.
Cut some pace if you want to get through it.
Absolutely, yeah. I was trying to move it on.
I know you were. I know.
Sorry.
Proud as ever.
Just,
This time we do need to move it.
I did a whole extra question at the end.
yeah.
That's a good question.
No, it's all important stuff. It's just
Just look at the health committee. There's so many witnesses.
Yeah, this is the.
yeah, it's the challenge, isn't it? I think I put you here. Okay.
Two colleagues are going to have a key now.
No, Andrew's gone. Still call it without Susan, as long as Andrew said she was going to
There's four of us in it.
Only 5. And a
Andrew's
clerk or
back.
two would be nice as well. We're going to launch as soon as we get someone in.
Because Andrew's back.
Yeah, we're in.
I think Susan's just popped upstairs.
Yeah, I know. Yeah. Wish you hadn't, but as soon as Andrew's back, we'll start. Well, we 12 to 12. Get it 10 past 12.
Have to really pace it up.
We're not quite core of it yet. We're just
Okay.
going to be. Yes, one of you goggles.
I've got very vocals first week as well.
Oh, really? Okay.
Yeah.
So we're sort of looking into
I know, it's very-
mid-distance and in a sort of uncanny way.
Going downstairs is a bit hazardous.
Oh, yeah, Good point. I'll think about that. Right, as soon as we have one additional member to the committee, we'll be launching, because I know time is a challenge, Neil.
That's
and,
fine.
Eddie's
Thank
all
you.
with us today.
Appreciate that. Thank you.
So we'll be moving apace, but very thoroughly apace.
Crisp answers, crisp questions.
Crisp questions, crisp answers, yes. And just bear with us while we gather people.
Right, there's Andrew, go.
Oh, right, we're in, Andrew, right, okay. I don't have to bash this thing, do I? We just move.
If you do it, just stop me.
I'll just do it anyway. There we go. We'll do that anyway, just for the sake of good order. Right, thank you very much. I welcome again our two guests who already were listening to the earlier discussion. Commander Neil Jerome, welcome again, and Rebecca Lawrence, of course. Welcome, Chief Exec. So really, we've gathered information from the earlier session. We've had work earlier from the round table. We really want now to speak to you on behalf of Met and MOPAC around a more strategic point around some of the issues that were raised. And I will start the debate initially to Neil. The number of detainees in custody suites continues to fall, we've heard. How do you monitor and model demand for healthcare services in custody?
You're absolutely right. So what we've seen, and it's not just a London phenomenon, this is a national phenomenon, that the number of people coming into police custody has been consistently reducing over the last 5 years. On average, it's about a 14% reduction in detainees coming through. Clearly, we have a duty of care to those individuals who are coming into our custody to ensure that they are held safely. And our custody healthcare model is one that responds to that. So one, it's about volume that's coming through, clearly, but there's also about the risk and the complex needs of individuals that are coming into our custody suites. So our healthcare model responds to that. It's a mixed economy healthcare model. It is one which is not dissimilar to a healthcare model that you will see in operation outside of custody suites, and it responds to and flexes according to the risk and the volume of individuals that are coming through.
Okay, because we heard about the model earlier, the complexity, and I know that there's been work being done on it, and I think you're going to get something signed off in May 18 around a confirmation of a model or the model. We can touch upon that as well. But what kind of impact does the current model have on the care of the detainees? So you've got an accepted model that you're going to have formally signed off, I believe. But what, in your perception, it's complex, it's difficult. What sort of effect does that have on the care and the workforce? Because we've heard about some of the pressures of the workforce. Would you like to comment on some of the things perhaps you've heard this morning?
Yes, I mean, the custody environment, and I have worked in custody. I have been a custody sergeant as well as having performed duties as a PC in custody. It is a complex environment. You're dealing with people who, some of whom it's their first time in custody, and others been in many times before. So it is a complex environment, but it's a teamwork environment, and it's a teamwork environment where custody sergeants, medical professionals, and others are at work in that environment to ensure that we investigate offences thoroughly and professionally, but also that we look after people effectively and safely. And the custody healthcare model, I mean, I recognise that there are stresses and strains within individuals who are operating in that environment. The work that we are undertaking is improving that situation. So in terms of our custody nurses and the numbers that we are recruiting and deploying into our suites is increasing. The number of our FMEs is broadly consistent with where it was 5 years ago. 5 years ago it was at 95 and it's now 89. So our level of healthcare provision is improving, it's getting better, it's a risk-based approach, and having dedicated nurses in a good number of our suites is definitely improving that position and giving support not only to our own staff but also to those detainees who are coming into custody.
I cover some of the subjects that mirror what we talked about this morning regarding the risks and the difficulties, but from the risk register point of view, what's towards the top and what are you keeping that close eye on? What worries, concerns you more than most?
So what we're certainly seeing is, I mean, fortunately in terms of our corporate risk register, this is now no longer a corporate risk for us. However, in terms of the way that we look after individuals, as we are seeing in outside society, we are seeing individuals who are presenting to us in custody with a great deal of complexity, be that drugs, alcohol, both, mixtures, dealing with individuals who are going through mental health crisis, as well as complex medical needs as well. It is making sure that we're alive to those, that we can discharge our obligations to investigate those offences for which they've been arrested, but also doing so safely. And it's making sure that we are alive to that and we're agile enough to be able to provide that service, which I believe we are.
Yeah, we're going to come to particular subjects a little bit later. Caroline.
To you, Rebecca, how are you overseeing the delivery of a safe and effective custody function, and how are you engaging with others in the workforce, such as the ICVs, appropriate adults, to get feedback to make sure that it's as good as it can be?
Thank you, Caroline. In terms of how we are overseeing this, transformation of custody is one of the strands of the Met's overarching transformation programme. You'll be aware there's been significant investment in the Met, in its own internal governance, in its own training of staff, and in its overarching transformation programme. And we receive regular reporting from the Met on that. So we oversee that through our oversight board and our investment advisory board. We also look at risk, and I think when we spoke in January, I described the revised and intensified processes whereby Met and MOPAC assess different levels of assess risk and come together with a shared view of corporate risk, which we again discuss through our oversight mechanisms with the Met and at our joint audit panel. You're right, we have other sources of information to inform our oversight, because we're not an inspectorate, but we have the reports of our independent custody volunteers, and you heard some of that earlier, and we have the reports of other inspectorates. So what are those oversight mechanisms telling us at the moment? Commander Jerome, I have a shared view with Commander Jerome here at the risk of quality of healthcare in custody has lowered from the corporate risk register as a result of the improvements that have been put in place in terms of resourcing of nurses and in terms of training. So that is encouraging. But we also actively ask questions from the reports that we receive. So, for example, this committee will be getting very shortly the next quarterly performance and finance report of the Met, which came to our oversight board only on Monday. That's reporting a pay underspend on staff, which led to very appropriate questions of, are there resourcing concerns or issues in custody and healthcare? And we were able to be offered assurance from the Met, consistent with the position that you've heard, that actually there's an improved resilience in that resourcing such that it isn't on a corporate risk register. So that's the kind of oversight we use through Met reporting. We do triangulate, of course, against the reports from our ICVs, which we review, and there are regular panel meetings. And again, it's a really important area to be vigilant on, and very much welcome this discussion and the work of this committee. But we use those to flag up to us whether there are any additional oversight questions we need to be posing to our colleagues in the Met.
So to your two boards that you mentioned, you have paperwork coming from the Met. It's how you then challenge that.
Yeah.
And so do you use, if you've had a report from ICVs, do you
Yes.
then at those meetings say,
Yes.
you're telling us this, but we've heard X and Y?
Yeah, absolutely. So
and that's documented,
yeah,
is
so
it?
we triangulated the current issues being raised by ICVs. There are very few issues being raised about the quality of healthcare. In fact, they're fairly complementary. We will come later to the questions which are raised from inspection reports, which we'll come to later, for example, appropriate adults and alternative facilities. And based on that, we use that in our partnership work to convene partners to see where MOPAC can do supportive action on where we don't have direct oversight control and the Met has to rely on partnership arrangements.
In terms of your own risk register, where is it on that?
So in our own risk register, we, like the Met, don't have healthcare in custody as a specific risk. But as when we last met in January, I was clear that child protection issues more generally are a key risk, and they are a shared risk, which leads to the issues around connected to the issues around appropriate adult and other provision. So those specific angles are very much on the risk register in the context of wider issues around child protection, which are familiar to you.
Yeah. Okay, if I could just pick up some of the staffing issues which we heard earlier. I'm not going to rehearse. We know that you're in theory on target to your 64 full-time equivalent nurse practitioners, and we've heard why it's been hard and some of the packages you're putting around. But is that enough, your 64? It seems to me, because you've revised it down, I know you're changing the number of suites, but is it enough? And I don't know if you heard some of the evidence earlier. It feels very stretched at times.
So you're absolutely right. So we will be at 64 come June. That will enable us to open 12 suites. There were challenges, as you will have heard earlier on, in terms of recruitment. Those challenges are no longer there, and we do have more custody nurses coming through. That will enable us to open a 13th base. That's going to be Heathrow, based upon the threat and risk from that. So this is a situation which we do keep regularly monitored and regularly reviewed to see what our provision looks like. And clearly bringing more nurses in will help that resilience. And our people do an outstanding job day in, day out, whether you're a police officer or a police staff in our custody suites, to keep people safe. And we're certainly increasing those resources that are coming in, as you've heard from custody nurses. And our number of FMEs is broadly where it was 5 years ago.
A new strategy or model that's going through your processes that may at last we will get to see, will that have a review mechanism in it in terms of staffing?
You're right, there's a full business case that is going to be presented in terms of our custody provision. That's looking at both the healthcare, but also in terms of our custody estate provision across London, and that's going through its internal governance processes at the moment.
Will that have in it a mechanism around staffing and reviewing?
So it does talk about healthcare. There is a recommendation in that, and subject to ratification, that remains an in-house model, but that we will clearly look to review that once we have bedded in the in-house provision that we've currently got.
Thank you. And then one of the other issues we picked up earlier is about how we've got FMEs, we've got the nurses, how they interact together, how they even meet, because often it's a voice on the phone, we heard earlier. What are you doing to help the professionals and others in custody build sort of networks, share expertise and training? And multidisciplinary teams was the words that came up earlier, and it's how do you make sure they are effectively a multidisciplinary team?
Absolutely. So what we have seen in the past through an FME-led model is FMEs who are covering a number of suites and effectively being peripatetic in terms of how they've been working. What we have done is we have reduced that level of cross-cover between custody suites, so that FMEs are now more based within single custody suites than they've ever been. That's the level of cross cover has been reduced by half. We think that with the all 12 custody nurse sites coming online by June, that will reduce even further. So I think one of the outcomes of that will be that there will be less travelling around, so that will then build those more effective multidisciplinary teams. And we also run custody update sessions. The last one was in November, of keeping our staff up to date with the local changes that are taking place, as well as the best practice that's occurring. So I'm confident that that is an improving picture, and clearly we do talk to our people and take on board their suggestions in terms of how we can make that better.
I heard earlier about dedicated training budgets that the nurses now receive. Are you doing some work generally about training with FMEs, nurses, everyone working together, learning from case studies and so on, so that they are all united as one team?
I think there's some merit in looking at that. What we wouldn't do is we would never seek to go through they have their clinical medical training. Clearly that's not a provision for us in terms of doing that, but in terms of binding that team ethos, absolutely, and certainly the way that we are configured at the moment and configuring into the future, we'll look to improve that even more by having a centralised custody command rather than having it dispersed across each of the boroughs. Does bring that sense of that one team activity of making sure that we're able to keep people safe.
Okay, thank you.
Okay, Susan.
Thank you. Earlier we were discussing with the gentleman call-outs of ambulances to custody suites, and we're concerned that obviously in the last 4 years this has doubled. So are you satisfied that every call-out is justified?
The position of calling an ambulance, I mean, we have a duty to keep people safe, and what we have done is learning from lessons in the past and making sure that our people receive the very best training, the very best awareness, is that since 2012 we have been improving the level of training that they receive, the protocols and frameworks in which they operate. And it's very difficult to say that there is no prescriptive checklist around when you should or shouldn't call an ambulance, and we trust our people to make those very fine judgments whether they do or whether they don't. But we will always put and always will put the safety of our detainees first and foremost. And so if someone is thinking whether they should or whether they shouldn't call an ambulance because of a medical emergency, we're not medical trained. It may well be that actually the ambulance is the best course of action. And I would absolutely trust our custody sergeants and our staff working in that environment to make that right shout.
Okay, they have gone up quite substantially though. Have you looked into whether they are all justified? Have you looked further into those figures?
I think there's some work that we need to do in terms of understanding that better, and that work is being undertaken to delve underneath it and explain the reasons why that might be the case. But absolutely, I would never discourage a member of my staff from not calling an ambulance.
But so it's interesting that what sort of work is going on to look into it? Are you actually looking to get all the figures so that there can be a robust set of figures around it?
And it's looking at the data, it's looking to see the number of repeat calls, because there may well be, there are a number of repeat calls in there, looking at the reasons why, looking at the outcomes, looking at what was the treatment that then took place in terms of that individual, and just delving underneath it to look at those reasons and whether we need to be more effective in our training.
I know the previous gentleman would be pleased to hear that. Who's actually undertaking that work, and when can we expect to have the work come back to the committee?
It's been undertaken by the Met Detention, so under my command. There isn't a timescale for that work at this stage, but that is something which is active.
Because obviously with 2 police officers having to go off every time with them, it must be a cost to the Met in that respect as well. Well, so are we looking possibly at certainly within the next 6 months? Will we have figures around it then?
I thought that would be a reasonable timescale, yes.
Okay, and then we can come back to you, or perhaps you'd be kind enough to let the committee know. We'd be interested. Thank you.
We look forward to that. Andrew.
Thanks. A couple of questions I've made just following up on Susan. We've got a note here of the meeting that Caroline had with Chief Superintendent Van Orden, and it says the Met is not actively trying to reduce ambulance call-outs. The Met Detention team will consider this as the figures do appear to be out of kilter. Are you or aren't you trying to reduce the number of call-outs for ambulances?
So we need to understand what those call-outs are, rather than say immediately we're going to reduce or increase. I don't think that's right, because each case needs to be judged on its merits. But what we do need to do is understand the reasons why those figures are as they are.
Because the number of call-outs has gone up while the number of detainees has gone down considerably. So it does, to me, it looks quite out of kilter.
So in terms of the actual proportion, but when you look at the training that we are improving for our staff, and you look at the frameworks in which they operate, their ability to spot issues of healthcare concern, I would like them to make sure that they are calling an ambulance rather than err on the side of not calling an ambulance.
If you are doing work on this, is one of the things you're looking at whether the ambulance are being called in relation to your repeat customers, as it were, as opposed who may be gaming the system, as opposed to a first-time detainee. I'm not saying that a repeat offender may not have a medical emergency, but they may know the system rather better.
I'm not sure our data will allow us to make that correlation. There is always a difficulty, isn't there? That there is a cry wolf mentality that somebody may, and I've experienced this, feign a medical emergency. And the fifth time that you do that, and you might say, actually, I think that they're feigning it, are they? These are really difficult fine judgments that my staff have to make day in, day out. And I absolutely support them in making sure that we keep people safe that are coming through. And if they need medical help, then that's what we will get.
Okay, well, can I go on to my main batch of questions, which is children and vulnerable adults? There's two issues. One is the availability of local authority care, and the other is appropriate adult scheme. Can I start with the appropriate adult scheme first? We've heard the suggestion that we ought to have a London-wide scheme. What's your view about that?
Well, I think it is a really interesting suggestion, and it's one that MOPAC we've discussed with London councils in the context of the Memorandum of Understanding on Criminal Justice Devolution, whether this is something where on a pan-London basis there could be cooperation around youth, because youth offending teams, as you'll be aware, also have a duty to ensure that a child has an appropriate adult. At the moment, there's a discussion. There's a starting point of a little, how should I put it, questioning or resistance from local authorities to go down that route. But we think it is still worth.
What's their objection to it?
Exploring. The objective is, would it be as effective as having local?
We know that locally it's not working.
I mean, I think this is a good line of questioning, and as I say, I think this is worth continuing to explore, which we are doing so in our discussions.
One of the issues that I explored with the previous panel was the issue of people actually knowing that we need to find appropriate adults.
Yes.
How do people volunteer? Advertising it. Could MOPAC actually do something about stimulating, either doing it itself, an advertising campaign? If it's going to be run by the boroughs, contact your local borough, or contact us in MOPAC, and we'll put in contact with how to do it.
I think that's an interesting idea. What we're doing in MOPAC is we've given impetus to the process, or created a process by which the Met and other partners on the London Children's Safeguarding Board and the Association of Directors of Children's Services, which have the responsibilities here, come together to look at an appropriate strategy for improving the provision of appropriate
well, that sounds like kicking it into the long grass, if I may say so.
Well, it's not. It's actually getting the consents and of the people who have a responsibility.
Well, I think it needs a bit of leadership, doesn't it? And you know, why on earth can't MOPAC or the Deputy Mayor for Police and Crime say, OK, we've got a problem here. We, MOPAC, will organise, on behalf of London councils, an advertising campaign to tell people about the need for appropriate adults, not just for children, but also for vulnerable adults as well, which we heard is a major problem from the previous panel. Why can't MOPAC take somebody and say, OK, we'll get to grips with this, we will fund an advertising campaign, because it's not going to be a huge amount of money compared to your budget, let's just get on with it.
That's an interesting idea. It's not an idea that the local authorities themselves yet have supported, but look, it is an interesting...
Well, have they been asked?
The Deputy Mayor has... The Deputy Mayor, through our cross-partner oversight of child protection issues, which, as I explained, is of high risk, has absolutely ensured that the London Children's Safeguarding Board and Association of Directors of Children's Services have a group actively looking at how to improve provision of appropriate adult scheme. As I say, it hasn't yet reached that point of maturity. They're looking at recording levels of demand and responsiveness for local authorities and mapping that out there. But yeah, we share your desire to see more action. With
appropriate adults, it seems to me as though it's many hands make light work, and if we've got a lot more, then the delays involved in getting people into the custody suites would diminish. The pressures on the existing ones would diminish. So, you know, how long is it going to take to make a decision on this? I think two issues, but they are separate. One is, OK, they can't make their mind up on London councils about having a London-wide scheme or individual boroughs, fair enough. But however you look at it, you still need people to come forward and do it, whether it's a London scheme or a local scheme. Why can't we get an advertising campaign underway pretty promptly? Because that doesn't cut across anybody's, stamp on anybody's toes by saying, well, we'll organise an advertising campaign.
Yeah, I mean, I certainly, the barriers to action here that we've identified in our partnership work, some of them do come down to responsibilities, resourcing and structures, including within the local authorities, to run the schemes. But you're absolutely right to be...
So how long is it going to take to make a decision on this?
So the decision is the decision is with London councils and local authorities on how they want to respond to this. But it's a
who's leading on this at local councils?
Martin Pratt from Camden is leading the work by the Association of Directors of Children's Services and the London Children's Safeguarding Board. So what he's doing is pushing work on supporting the Met in looking at levels of demand, responsiveness from local authorities, data sharing, so that local authorities have a shared view of what the problem is to move onto the solutions. We put, as I say, we put last month a proposal.
First of all, is there a shared view that there aren't enough appropriate adults?
I think, we agree with the work. We, amongst ourselves, there is a shared review, and we agree with the questioning of this committee.
Is there a shared view in London councils that there's a problem?
There's a shared view that they're looking at the data. There's I think there's a disparate view amongst local authorities because there isn't a shared view of the consensus of what the solution is.
It seems to me that this has been drifting for months and months and months, if not longer. Somebody needs to get a grip of it, don't they?
And I'm delighted that the Directors of Children's Services are taking leadership here, encouraged by MOPAC and the Met.
Well...
I'm not sure if you have other evidence sessions at which local authorities have been invited, but it would be very fair questions to ask.
Yeah, well, we do have sessions with local authorities from time to time, but are we going to have this discussion in 6 months' time?
I hope not, because we have a police and crime commitment, as you say, to take it forward. These questions are very welcome, and we take seriously the reports from HMIC, and this is a joint shared risk on our risk register, that other authorities support us in the work here. I mean, it's worth saying the last London Crime Reduction Board that the Mayor chaired, the minutes of which are up on the website, there were discussions, quite active discussions, on the pressures faced by both Met Police and by local authorities, and you'll be aware London Council shared a paper there on the very, very significant pressures they face in their budgetary position.
So we've had discussions about it, but was there any outcome?
As I say, I just refer you to my earlier answers.
No.
It's work in progress, and the spotlight is welcome.
Can I go on to the other issue, which is availability of non-secure and secure accommodation? Yeah. Now, we heard from Sergeant Watts, who says it's been improved from the sense of going from 0 to 1 in 8, which doesn't sound a major improvement to me in relation to non-secure accommodation. In relation to secure accommodation, there isn't any. So again, obviously it's a pressure on local authority budgets. When you're looking at secure accommodation, I think we had this discussion last time we went over the houses. There probably isn't enough demand for one individual London borough to do this in that particular borough. So why can't MOPAC bang a few heads together and say, okay, we will have a lead borough, we will coordinate one lead borough organising this on behalf of London?
Part of me would love to be able to say it was that straightforward, but it's hard to do that without the consent of local authorities to say they want this work to happen. So the group chaired by London Councils, multi-agency group, it involves the Met, it involves ourselves, involves NHS England. There is a really good collaborative partnership there. It has been gripping the issue of problem identification and then solution identification.
The problem of a lack of secure accommodation goes back years, doesn't it?
It does.
Right. So everybody knows there's a problem.
Yeah.
Yes. So the next question is what we're doing about it. Answer, talking quite a lot and not actually delivering anything. And it must cost a fortune to send people off to Leeds and Manchester and Wales and Bristol and all these other places we're sending people to. And also putting pressure illegally, as it were, on the Met to hold these people in custody when they're not supposed to be in Met custody. Why can't MOPAC take a lead here and say, OK, let's bang some heads together and do something about it?
I think certainly what we've done to support that is that there was a case, and you've heard from Sergeant Watts that my colleagues knew inevitably what the outcome was going to be when they made those telephone calls, and therefore we weren't collecting that data. We have been collecting that data. You can see there that whilst there are some challenges with the data, we are getting much better. I think that then supports our colleagues to then say this is the case and this is the requirement, so that we can
we had
articulate.
394 requests for secure accommodation, placed 2, which is hardly a very good record, is it? I mean, I'm not blaming Commander Jerome, because it's not your job to provide it. It is the job of local authorities, and to my mind, it's the job of MOPAC to try and pull all this together and do something about it. And we've had this discussion, I don't know how many times in this committee, about it being a problem, and there seems to be lots of discussions and papers, but nothing actually seems to come out the other end. So why doesn't MOPAC take a lead and start banging some heads together and say, we have to do something about this? You know, if all the 33 London boroughs plus the city come together, it shouldn't be beyond the wit of man for one of them to become lead borough and provide us accommodation somewhere. It's not as though we need hundreds of places on any one day, is it?
Yeah, I mean, I share your frustration in many senses. I understand where you're coming from, and they're very good questions. And I share your frustration that the dispersal of budgetary authority, the dispersal of legal authority means that decision-making processes invariably, even with a strong convening role, and we've tabled this firmly on London Children's Safeguarding Board agenda. We've established partnership groups. But the fact of budget pressures and dispersal of decision-making means those are the kind of issues. Those are the kind of issues which create for ongoing risk.
But,
and
I mean, looking at these numbers, you probably need 10 beds a night on average. Across 33 London boroughs, you can't find the money to provide 10 beds on average a night. It doesn't. I mean, never mind. I haven't even talked about the non-secure accommodation, where we do seem to be making minuscule snail's pace progress. But it does seem to me that somebody needs to get a grip of this, and nobody is.
Okay, I think your point's met. Well, we'll certainly have some recommendations around that. Do you want to add anything, Caroline?
Just very, very quickly, I'm conscious of time, but Commander Jerome, I want to pick up the latest HMI report on child protection that came out in February, has a really damning case study about a young boy who's in custody for 38 hours. His risk assessment was not updated, even though he'd been found trying to hang himself in his cell, and he was marked as fit and well for transfer to court. What are you doing to ensure that custody staff are properly trained in child safeguarding and that every process is being followed? I just wanted to comment on that.
Completely, we take that really seriously. Already this week, custody training is being rolled out for all of our custody inspectors to make sure that we keep them refreshed and updated in terms of their safeguarding obligations, and making sure that we are able to review those instances, learn the lessons. One of those is updating the training. That's already started this week.
And Rebecca, are you overseeing that at MOPAC?
Yes, absolutely. The Deputy Mayor has monthly child protection oversight meetings involving all partners to follow up the HMS's recommendations. Okay. Absolutely.
Good, thank you. Sean.
So moving on to the liaison and diversion issues that we raised. Obviously the healthcare in custody is run by the police, but this service is coordinated by the NHS. Yes. We don't have someone from the NHS here today, but maybe the Met can outline what steps you're taking to make sure that all the detainees who should get liaison and diversion services can get them, and how you're working with the NHS to improve that.
So certainly it's a collaboration that we really value, and I think it's a very strong partnership. So some of the areas that we've taken to improve that relationship have been dedicated provision of office space and having those individuals actually co-located as opposed to coming in and out. I think it's really strengthened that. In terms of the referral process of referring detainees into liaison and diversion, and making sure that our staff are fully aware of that's available, and also the mechanism of making that referral. But I think by having those co-located and having those staff working as part of that one team does lead to some very, very strong working relationships.
Earlier on we heard that there were slightly fewer, it seems, of the borough type, we don't look after these people kinds of issues going on. Has that been easier because you're working with the NHS to get over the sort of territorial issues of who comes from.
There is always going to be a challenge about geography, clearly there is, but certainly I think in terms of the way that the NHS is configured across London does make that slightly easier. We're working with Liaison and Diversion services to increase the scope of their provision. You'll have heard in terms of the hours and the days of the week. We'd dearly love for it to be 24/7, 7 days a week, but I do understand that there are resourcing pressures for that. But we work closely together to see how we can improve that provision across London.
Rebecca, do you have anything to add to what MOPAC's doing to keep an eye on
No,
that?
I mean, we keep this under review, and I think the support provided by NHS England is you know, really quality, and there's a really quality partnership there. And you've heard earlier today the very, very welcome difference that this service has made, and it's a real shame for very sad reasons that our colleague can't be here herself to describe that. Okay. But I'm really confident in the partnership and the effectiveness of the partnership there.
Thank you. Right, last questions again on the subject of death in custody. Umesh.
Thank you, Chair. If I could start with you, Ms. Lawrence. So in terms of the Met's treatment of detainees, I mean, how do you scrutinize this treatment and the handling of cases where death or injury has taken place? Could you give us a broad overview?
So as you know, we don't have the powers to look at individual cases and investigate that, but we absolutely look at the reports by IPCC, ASWAS and IOPC on when there are, sadly, tragic incidents, and look very actively to make sure that the Met, through its organisational learning and development processes, take on any of the lessons learned that may be the case arising from that. And of course, in the risk process I described, we would look at whether there was, and the Met would identify whether there were issues in the data that were showing there were big problems there. But I think, as you heard earlier in the earlier session, I think we would both agree with the analysis that you know, each of these incidents is a real tragedy, but the volume is relatively low compared to the high level of numbers of detainees coming due to the care and the control around the environment.
Come back to you, but Commander Jerome, if you could tell us what is your own assessment of the handling of such cases, and more importantly, what improvements need to be made to the way it works, in particular with families and friends of people who come to harm in custody?
So you're absolutely right. I mean, in terms of its occurrence, it's extremely rare, which is thankfully really, really good news. There is significant oversight in terms of any death in custody. Not only is there an IOPC investigation of that death, there's also a coroner's inquest into that. The Health and Safety Executive have obligations as well. So there is significant oversight in terms of any death that occurs. In terms of support for friends and family, you'll be aware that within the over 100 recommendations from Angiolini report, that one of those is about provision of victim support and support to families. For matters of independence from policing, that would not be provided by the Met, but would be one of those recommendations is that it's provided by an independent provider.
All right. So this is an area that does concern me, especially with some of the deaths we've had over the last year. I mean, what more can you do to communicate with families? Because there is this belief, perception, call it what you want, that the transparency isn't there and families are left out of the of things, whereas this should be the center of the investigation. And have you given much thought as to what improvements can take place in light of some of the incidents we've had in the last year?
Certainly what the Angiolini report makes absolutely clear is that is a area of improvement for the Independent Office of Police Conduct, that it's those individuals, they are the investigators, they complete those investigations, and they also have the responsibility to keep the family updated. The Met would not investigate deaths within custody for very clear reasons that there does need to be that independent oversight that is required under Article 2 of the Human Rights Act.
So, question of the time, Chair. So, you already referred to the recommendations arising from the Angiolini review, touched on 1 or 2 areas. So, if you could tell me what other progress has been made on implementing, I think, the 117 recommendations?
When you look at those,
We've got the same question to you after that.
when you look at those recommendations, the majority of them are not to do with policing, and those that there are national recommendations that are being taken up by either the College of Policing or the National Police lead for those. Internally within the Met, we have a gold group structure under a Deputy Assistant Commissioner for Professionalism, who has a regular gold group meeting, which includes myself, to look at those recommendations and to report back to him in terms of the progress that we're making, albeit that specifically those recommendations do not fall to the Met ourselves, but notwithstanding that, we are taking it seriously and looking at how we can improve.
And we engage with our colleagues with the Met to satisfy ourselves that is in hand, and that the wider discussions amongst policing nationally take place, and that through the Met's future custody model that is robust and as resilient as possible.
When you say engage, I mean, my question, how can I put this? Is it more to your liaison with the Met, rather than engaging? Are there any proactive measures by you in terms of, pushing? I know that not all the recommendations relate to the Met, but as far as they do.
Yeah, I mean, it's our risk-based approach to oversight that I described earlier. So where there's an impact on a negative impact on outcomes, that flags in our quarterly systems of ensuring there's appropriate action on.
And we've had a discussion within the organisation about those recommendations and the appropriate way of feeding back to the Home Office, because it is a Home Office sponsored report around the actions that we've taken. And then clearly, once we've decided what that appropriate feedback mechanism is to the Home Office, that will also include liaison there with MOPAC as well.
I think we wanted to finish by 12:15. We're coming up to 12:15, so I'll leave it
I think that's perfect timing. And again, thank you very much for your full and thorough and to the point answers, everybody in the chamber. Again, thank you all guests for attending today. Can I just ask a couple of brief bits of work? Can I ask the committee to note the report and the discussion and delegate authority to me with consultation, the output, and there will be some output around this from the things we've heard this morning that I will share with group leads. Item 6, can I ask the committee to note our updated work programme and ask the committee to delegate authority to me to agree arrangements for the visit to Gravesend. Item 7, date of next meeting is the 21st of March, 10 a.m. Item 8, I have no other urgent business. Again, colleagues, thank you very much this morning.
Perfect timing. Well done.
GLA Chamber